We're going to talk about pregnancy screening, first, second, third trimester, and what we're looking for in the pregnancy screening. So what are the signs of pregnancy? I guess this is important to know. So there's a bunch of signs. There's Chadwick's sign, which is looking at the blue. You see a blue hue on the cervix and vagina. This is not the same thing as blue waffle. But if it helps you remember it, Chadwick does have a W in it. If you want to correlate the W with waffle, then remember blue cervix, blue waffle. That's fine. Next we have Goodell's sign. This is basically the softening of the cervix, so you can feel the cervix while you're doing the manual exam. And if the cervix is soft, then that's a sign of pregnancy. Next is Hegar's sign. This is the softening of the lower uterine segment. So what you do, I'll try to draw this. Let's just imagine that this is the vaginal canal. Here's the woman's belly. And you've got your finger in here pushing up against the anterior aspect, and with your other hand you push down right here and you feel for softening. I know this sounds crazy, but if you're pregnant, your belly gets big. The other thing, pigment changes. Pigmentation, it can change all over the body. One of the good indicators is the color of the nipples. Also the size of the nipples will change. Stretch marks. Some people get up to like 25, 30 weeks pregnant and they don't know they're pregnant. Usually it's people that are obese, but if they have recent stretch marks, that's a pretty good sign that their size has changed. Now lastly is ballottement. Well, it's not last. The last is take a pregnancy test. They're cheap. They're way more accurate than any of these other signs. Just take one. But ballottement. So ballottement is, again, I'm going to draw, this is the vagina. You got the cervix here. Here's the uterus with the little baby inside of it. And if you push your finger against the cervix, it should, this is, I think I'm understanding ballottement correctly. I could be wrong about this. It pushes the baby this way, and then you release a little bit, and you feel the baby pop back down and kind of bump back down. And that is the ballottement sign. Now, just a caveat, I totally could be wrong about understanding that. The way it was written in the text I read was slightly confusing. However, bottom line, just if you think pregnancy, $3 at Dollar General pregnancy test. They're up to like 98% accurate up as early as 6 weeks after your last menstrual period. So go ahead and do it. And what changes can you expect while you're pregnant? So there's going to be heart changes. Of course, the heart murmur is heard in most pregnant women. It's going to be a systolic murmur. A diastolic murmur is still abnormal. Now, why is that? Well, you get increased blood volume, up to 50% extra blood while you're pregnant. Your heart increases by 30%, and then you get an increased cardiac output. Let me put the T on there. Output 30 to 50%. Now, you're going to expect, with the increased blood volume and everything, you're going to expect the murmur. You're also going to expect extra splitting on S1 and S2. If S3 isn't normally heard, you still might hear it during pregnancy. S4 is still abnormal. Any murmur above a grade 3 is abnormal. Cyanosis, clubbing, any of these signs that oxygen isn't getting where it needs to be, abnormal. And a JVD, even with the extra blood volume, the extra cardiac output, you still shouldn't have jugular venous distension unless you have heart failure. Okay, so talking about trimesters, you have 3, obviously. When are they? You remember 3 up to 13 is your first trimester. So last menstrual period up to 13. That means the second trimester starts at 14. If you add 14 to 13, you get 27. And then weeks 28 up to the delivery is the third trimester. Okay, everyone wants to know when their due date is, right? That's the big thing. Like, oh, I'm pregnant. When am I going to have the baby? There's a bunch of ways of determining this. So if you know what your last menstrual period is, you always have to know what the last menstrual period is for any of these calculations to work. But typically it's 280 days from the last menstrual period. So some studies will say 281, some others will say 281 for the first child and 280 for the second. The standard deviation depends on the study you look at. This one study was about 7 days, another one was 13. So what does this mean, standard deviation and all that? That means, like, if your due date is right here, then up to 7 days before and 7 days after, any one of those days you have a 2 to 3% chance of the baby being born on that given day. You have about a 4% chance of the baby being born on the due date. But within this range of 14 days, you have approximately a 66% chance of the baby being born in that range. And then if you go out 2 standard deviations, so now we're 14 days prior up to 14 days after, in that range you have something like a 96% chance of the baby being born in that range, so in that 28-day period. But any given day, again, 2%. So this, by the way, would be a great way to make a good lottery at a baby shower. Have everyone bet on a specific day that the baby's going to be born. They only have up to a 4% chance of being right, even if they know the due date. And then again, that depends on which study you look at, because I'm only going off the 7-day study. I'm being generous. There's another one that says 13 days. And if it's 13 days, that lowers the percentage down even further. Now, why do we have variability? Oh, let me back up a bit. 266 days from conception is typically a better way of judging things, because whenever you menstruate, that first part of your cycle, the first half of your cycle, is the most variable. From the time that the egg is released, the time of ovulation, that's the least variable time of your cycle. And so you have a lot of variability. So everyone will say last menstrual period, and then day 14 is ovulation. This first part is the most variable. Then from here to the end of the cycle is the least variable. So we know that 266 days is a better measurement if you go from the day of conception, but not very many people know their exact day of conception. Another thing that apparently can play into this is your cycle length. So Nagel's rule, which is to estimate, I'll go over what Nagel's rule is, but it doesn't take into consideration the cycle length. There have been more studies done on using Nagel's rule, and I couldn't find any studies that used Parek's rule to see how close it got to the actual due date. But Parek's rule basically says if you add 9 months, because we're going to say a baby is born at 9 months, and then you subtract 21 days. So what does that do? A normal cycle is going to be 28 days, or that's the so-called average cycle. So if you do that, if you have a normal cycle, then your baby will be born at 9 months, or we're estimating at 9 months and 7 days. That is exactly 280 days from your last menstrual period. If your cycle is less than 28 days, then you're going to have less than 9 months and 7 days. And if your cycle is more than 28 days, you're going to have more than 9 months and 28 days. So it's a pretty simple rule to follow. But most of the time, if you're after the month of March, if you're adding 9 months to something, that means you're crossing a calendar year, and people don't like to count up to 9, and some people aren't quite mentally capable of keeping track of 9 months and then crossing a calendar year. So Nagel has a much easier rule to remember. And Nagel's rule is the one that most used in clinical practice if you don't have one of these calendar things. So let's say that my last menstrual period, I had my menstrual period on, let's say, May 14th. What I'm going to do is add 7 days to that. So I'll be at May 21st. And then I'm going to subtract off 3 months. So April 21st, March 21st, February 21st. So right now I'm in 2015. So we started this at May 14th, 2015. That was when I had my first day of my last menstrual period. And so I added 7 days, I subtracted 3 months, now I'm going to add a year, 2016. That would be the due date according to Nagel's rule. But you would not believe how many women do not keep track of the first day of their last menstrual period. I think I would remember, but I'm not a woman, so I'm not judging. Well, I kind of am, but I'm not. But that's okay, because we have something called ultrasound. And what ultrasound does is in that they can measure something called the crown rump length and use that to determine almost exactly how old the baby is. Now, if you kind of know what your last menstrual period is, you're not exactly sure, and then you use the crown rump length to estimate gestational age, if this number here and this number here are within 7 days, and again, some people use a 7-day rule, some people use a 10-day rule, Just depends on where you're at, what country, I guess, which publications you like to follow. So if these two numbers are within 7 days of each other, you go with the last menstrual period. Other things can be used to estimate the delivery date, for example, femur length and the various lengths of the long bones, and the circumference and diameter of the head. All these things are obtained on the ultrasound. So you're going to start having visits to your OB-GYN, and in that every visit you should have your blood pressure and weight checked. You should have a urinalysis. The urinalysis is going to look for protein primarily, but early on it may also look for glucose because early indicators of gestational diabetes. Then checking the uterine size, and that'll either be through an ultrasound and or by measuring the fundal height. Fundal height is basically, you got the woman's belly here and her legs here, and you measure how high the fundus is with a tape measure. And by doing that, you can estimate the gestational week of the child. So usually this is the most accurate between the 20th and 30th week, but the fundal height will equal the gestational age. And I'm pretty sure that rule works in metric, so 20 centimeters, 20 weeks. Every visit, you're also going to have heart activity monitored in the baby, and later on in the pregnancy, the doctor's going to ask mom if the baby is active. How active is he? Is he moving a lot? What times of the day? Are there times where he's not moving? You're just kind of checking for sleep-wake cycles, checking for activity, development of the baby, and that kind of thing. And eventually that's going to be important for something called the biophysical profile. I won't go into that in this video, but I'll get into it in another one. So in the first trimester, the visits are going to be specifically going to establish a baseline blood pressure. This is going to keep track of preeclampsia. So if you normally have a high blood pressure, your blood pressure needs to go up much more before you start worrying about preeclampsia than if you normally have a low blood pressure and it goes up. So you're going to examine the uterus, look for different types of cancer, look for different types of infections, STDs, STIs. And then the routine labs. So routine labs are going to be Rh and antibody screen, because if you have Rh negative mom, Rh positive baby, you can have something called hemolytic disease of the newborn, or HDN. You're going to check mom for anemia. There is sort of a phantom-like anemia that happens in pregnancy because the blood volume goes up so much and the red blood cells doesn't go up quite as much as the blood volume. And so you get so the values for anemia have to change a little bit. The hematocrit values have to change a little bit for a pregnant woman. But you still want to evaluate for anemia. She may need iron. She may need different folic acid, B12. And just to belabor the point a little bit, the normal hematocrit for a non-pregnant adult is between 35 to 44. And by the third trimester, the normal hematocrit for a pregnant woman is between 28 and 40. Now the rest of it, you're going to look for immunity to common torch infections. I've done another video on torch infections, and that's up on the YouTube channel. Also, you're going to do urine culture. And on top of the culture, you're looking for urinary tract infections, but you're also going to check urine protein. And then the STIs, you're going to check for all of those. Big one being HIV. It's so big, in fact, I listed it twice on accident. In women that are at risk for various diseases, you check various different things. So you want to evaluate thyroid function. Type 2 diabetes, if a person's at risk for that, you want to evaluate gestational diabetes also. Different diseases, so for example TB, if a person's had TB before, you want to make sure everything's going okay, they don't have an active infection. Toxoplasmosis, Hep C, bacterial vaginosis, trichomoniasis, which I've got trichomonas is the name of the organism, but trichomoniasis is the disease, HSV, CMV, Chagas. And then you'll look at inherited disorders that they may have, cystic fibrosis, Fragile X, hemoglobinopathies, and phenylketonuria. Lastly, check for lead levels. And then after that, you're going to screen for aneuploidies. And I'll explain that a little bit better here in a second. In the second and third trimester, it's a little bit more variable. So week 15 to 24, you're looking for neural tube defects. That's the aneuploidy screen. this can happen, the best time to do it is between weeks 16 and 20, but it can happen between 15 and 24. Also, you're going to check for gestational diabetes, antibodies on red blood cells, so you might do an indirect and direct Coombs. Then you check the hemoglobin and hematocrit for anemia again. And you'll notice I have 48 weeks here. That's like the upper limit. If you don't have your baby by 48 weeks, there's a very high chance that your OBGYN has already recommended to you that you do a cesarean section. Usually around week 35, you check for group B strep, and then you will also do estimations for the fetal weight to make sure that he's growing properly, and that's done on ultrasound. And then the big thing, this is supposed to be 41, between 36 and 41 weeks is patient education, just what to expect, delivery, after delivery, the first couple of months of having a new child, and that kind of thing. So how many visits are you going to have? So if you go and see your doctor at 6 weeks after your last menstrual period, you're going to have a visit every 4 weeks for the first 2 trimesters. So that's up to 28 weeks. So what's going to happen, you see him at 6, 10, 14, 18, 22, and 26 weeks. So you'll have those 6 visits. Then from week 28 to week 36, you'll go every 2 weeks. So you'll see it 28, you'll see it 30, 32, 34, and 36. Depending on your OB-GYN, you may not get that one. Then after 36 weeks, you're going to have them every week. So you'll have 37, 38, 39, and 40. If you deliver on the 41st week, that gives you a total of 16 visits to the physician. Most women average around 15 visits to the physician. Now, testing for aneuploidies. Aneuploidy is whenever you have a non-disjunction during meiosis. So basically, you have an extra half of a chromosome. And so an extra half of the 21st chromosome is Down syndrome. An extra half of the 18th chromosome is Edwards syndrome. And these are the two, well, there's more than aneuploidies than that, but these are the 2 main ones that get screened on the QuadTest. And there's patterns that you look at. So the QuadTest will measure inhibin A, beta HCG, alpha fetal protein, and unconjugated estriol. And so the pattern you want to look for in Down syndrome, if you have inhibin A and HCG high with AFP and UE3 low, then that's a strong indicator of Down syndrome. And then what you'll want to do is do a non-cellular DNA check on the mom. So some of the DNA, some of the cells in the baby will break off, get into mom's blood circulation, and that free DNA, that non-cellular DNA, acellular DNA, you can check that within mom's blood and check for Down syndrome that way. With Edwards syndrome, trisomy 18, when all 3 of these are low, so HCG, AFP, and UE3 are low, that's an indicator of Edwards syndrome. And then just having one or both of these high with the rest of them normal, that is just an indicator of adverse outcomes. So any number of adverse outcomes could happen with that. And so that's just an indicator of that. If unconjugated estriol is low and everything else is normal, that can be an indicator of Smith-Lemli-Opitz syndrome or X-linked ichthyosis. And I'm just listing the big ones, the most common ones. There's a lot of other things that this QuadTest kind of gives you an insight into. If you have a high alpha fetal protein, that's an indicator of a neural tube defect, and that can also be an indicator of other things. So alpha fetal protein is basically like it's what's made in the child's liver before they're born, and it's basically the antenatal version of albumin. And so whenever there's a neural tube defect, that albumin or alpha fetal protein can get out into the area of the neural tube and then leak out into the amniotic fluid, and then of course it can cross the placenta as well. I think as far as our tests coming up, these are the two main ones that we would want to keep in mind with the quad test. The main purpose of the quad test is to check for aneuploidy. And so Down syndrome, HCG and inhibin A high, AFP and UE3 low. Now, last thing I want to say about this, I bring up quad test because it was brought up in one of our cases, but this is not the only screening test that you do for the baby. In fact, this is the second trimester test. There's also a first trimester test, and whenever you do them both, it brings up the accuracy of the overall test for detecting aneuploidies and other diseases that the baby may have to deal with after they're born. All right, next thing you're checking for gestational diabetes. Now, there's a little bit of disagreement about exactly what gestational diabetes is caused from, but there's also a disagreement on how to check for it. So basically, it's carbohydrate intolerance brought about by physiologic changes during pregnancy. So you can't properly maintain your carbohydrate levels in your serum because of the pregnancy. Now, most people will say that this is just pregnancy unmasking diabetes, type 2 diabetes that already existed. Other sources will say that that is only the case sometimes. So you already have a glucose intolerance, but it's not very significant, and your pancreas is making all of the extra insulin that it needs to make to keep that in control. And so when you get pregnant, it becomes unmasked. The body's metabolism changes significantly enough that the type 2 diabetes is no longer able to be controlled by extra pancreatic production. Now, I went ahead and put this chart on here. This chart is from the American Diabetic Association recommendation. And the ADA recommends to do a single test for diabetes. And basically what they say is after fasting, so you fast, and then you take 75 grams of oral 75 grams of oral glucose, and then you monitor that. And after fasting, your should not be greater than 92 on your blood glucose after fasting. So these, in the United States, most of the time we use milligrams per deciliter. We also have millimoles per liter over here. But anyhow, you should not be above 92 milligrams per deciliter after fasting. If you become over 180 after an hour or over 153 after 2 hours, if any of these numbers get exceeded, then you have diabetes, type 2 or type 1, depending on whether it's caused by the failure of the pancreas or failure of the body to respond to insulin. Now, this single-step test, the American College of Obstetrics and Gynecology says there's not enough evidence to use this test for pregnancy. So we're going to use the old-fashioned two-step test and keep doing that until more evidence becomes available. I'll explain what that two-step test is in a minute, but anyhow, the risks of gestational diabetes, what happens is you can get stillbirths, polyhydramnios, macrosomia, and preeclampsia. Those things become more significant whenever you have gestational diabetes. So this is basically like a spontaneous abortion. The baby does not survive through the pregnancy. Polyhydramnios is where you have extra amniotic fluid. Macrosomia is where the baby grows way too much or grows really big. And one of the problems with this is whenever you have a really large baby and you're giving delivery, then the baby can become stuck inside of the birth canal. So that can cause dystonias of the shoulder. You can cause a lot of problems in mom, ripping, tearing, bleeding, that kind of stuff. So you want to kind of make sure you have that under control. Preeclampsia is the most severe thing that is on this list. Preeclampsia and eclampsia are both really severe problems I'll get to in another video, but happens with pregnancy. So let's talk about this two-step test. The first step, 50 grams of oral glucose. If the plasma is less than 140, you're okay. If it's greater than 140, you move on to step 2. So you take 100 grams of oral glucose after fasting. If your numbers exceed 105, 190, or 145 within 1, 2, or 3 hours, then you're diagnosed with gestational diabetes. So in this two-step test, you're taking 150 grams of oral glucose. In this one, you're only taking 75 grams of oral glucose. I don't know what the evidence points to, and I don't think anyone's going to know for a little while longer because we're still doing this test on pregnant women, so it's going to be harder to get all the data on pregnant women to see if this test is sufficient. But by the time I start practicing, if I decide to do obstetrics and stuff, then I'm sure that someone will have made a decision by then, and this rant will be obsolete. The treatment for gestational diabetes, basically the same thing as type 2 diabetes, diet, moderate exercise. So when you're pregnant, there's some risk factors with exercise, like if you're bleeding or spotting in that first trimester, you're probably not going to be able to do any type of exercise. You're going to be put on rest, and then later in pregnancy, it's going to be harder to get the exercise you need. But going on daily walks, take a mile walk, that kind of thing. So diet, exercise, and oral hypoglycemics, so stuff like metformin. Now the pathophysiology, like I said, it's not completely known. It may be similar to type 2 diabetes mellitus, and it may be an unmasking of type 2 diabetes mellitus. So anyhow, what happens is what we think happens, the baby starts producing chorionic somatomammotropin, and this is in order to help the baby get all the nutrients that it needs. When that's secreted, it basically can cause insulin resistance. It causes a slight insulin resistance. And so if your pancreas is able to keep up and produce extra insulin, then you're fine. But if it can't do that, then you're going to have a high blood sugar. Now, one of the indicators that say that this is basically the same thing as type 2 diabetes being unmasked is that all the risk factors are the same. So obesity, ethnicity, age, and family history. And that is the basic workup and what your physician is looking for during the pregnancy. There are some other things. If there's complications, if there's stuff like preeclampsia or serious diseases, then of course other things are going to be involved, but those are the basic screenings and the basic visits for OBGYN pregnancy visit.